Good morning, good afternoon, good evening, and welcome to one of our webinars. This time we're going to be talking about laboratory operations during the pandemic. With me today, one of our guest speakers today is going to be Joseph Damokong. Joseph is joining us out of New York City, New York. Joseph is the Director Manager of the Microbiology Research and Department, R&D Department, Research and Development, and viral microbiology. And he will be giving us a nice conversation into what goes on in running a laboratory during the pandemic. As I said earlier on, the whole idea was basically just to ensure the fact that we can do the relationship between what standards would do to us and our actual testing in the testing world. And as I said, Joseph Damokong is the manager of the Microbiology Research and Development and Molecular Virology at Empire City Laboratory in New York. And Joseph is actually in an everyday use of a laboratory and has had to actually work within the pandemic. And we invite him today as our guest to tell us what it looks like working in a high complexity laboratory and trying to manage the events around commodities and the whole idea of between commodities, changing testing platforms, and ensuring that the test actually is able to go on. So as I said, it's going to be standards. It's going to be the relationship of standards to where we are. And the big standard that we look at today is the standard ISO 15189. That's the standard that predominantly looks at what happens in laboratory medicine. But then, of course, there is the whole area of biological evaluations, looking at medical microbiology, which is for most laboratories, that is where molecular biology actually looks at. And then there is a whole standard that ISO 16578, the 2003 edition, is a prime standard in terms of looking at molecular biomarkers and how we can do the testing around them. So just to be able to get into all of these, there is a very important factor that needs to be seen. And that's what is actually going on today, is the whole area of emergency use authorization. And this is a very important area to do with the testing that is going on. And Joseph, I'm going to allow you to talk some more about this when we look at the global relationships of testing. But just to be able to find out, it is grounded in the fact that the FDA, the Food and Drug and Cosmetic Act, allows for reagents for test diagnosis to be used in terms of treating diseases in conditions where there is nothing that is known to be able to work for that. And that's basically what the emergency use authorization gives. In terms of testing capacity, there are actually basically two platforms for testing. There is viral test and antibody test that can be used to do testing. And from that point, the viral test basically looks at the amount of RNA and the virus protein in terms of antigen testing. And then we can also do antibody testing, which is serological testing, or more or less using of blood to be able to do the test. So in essence, there are four screening, diagnostic, and monitoring tests that could be used. There is the reverse transcription polymerase chain reaction test, commonly known as the PCR test. There is the loop-mediated isothermal amplification, LAMP testing, and the lateral flow, which is part of our rapid diagnostic testing. And then there is the enzyme-linked immunosorbent assay, more commonly known as the ELISA test. Those are the four basic tests that are out there. This profile, the test profile, basically addresses the issue of time. That's really what I want to bring to your attention. More and more people are wanting to get results quickly. A lot of airports, points of entries are open today. And the big thing is you must have a negative test. It must be a PCR test before you travel. But there are other people who just want to do the test because they're anxious. There is an anxiety level that exists. And so we have different tests, time from 3 to 6 hours with the regular RT-PCR, all the way down to the ELISA test or the lateral flow test, which will take you about 20 to 45 minutes in most cases. This is a very important slide. This slide is important because there is still a lot of talk about people testing positive one day, testing negative another day, or testing negative and positive, and trying to understand what actually happened. This is a slide I'm actually using from one of our previous presentations. But what we're seeing here, if you look at the very top part of this slide, we're looking at an incubation period right up here, which generally is from -14 all the way to 0 days. And in this period, any test that is done here, especially if you're using the rapid detection test, you're going to certainly have a negative result. And then you have the presence of the virus coming up in the test phase. You have the presence of the virus coming up here, and then you have the IgM and IgG slide coming up here. And these are the present. This is where you actually begin to get results. But this is what is actually important in terms of understanding the test, and it's actually the COVID testing pyramid. Understanding where the incubation phase is, understanding where tests that will actually give us a positive and a true result of what is the actual viral state of the patient is actually in this second slide, because you have an incubation period, you have a symptomatic onset period, and then you have the nucleic acid amplification test diagnosis window, which is a very crucial part, because that literally takes you from day 4 all the way to day 14, which has come to be known as the magic period for testing and identifying people as positive. Then, of course, then you have the symptomatics fall off, and then from that point going forward, any NAT test that is done at this point, literally you're going to have a negative result. However, at the same period, if you look back at the first slide, at the same period, if you had a rapid detection test done, an antibody test, you would show a positive result, but actually the viral load is actually reduced to 0 at this point. And then, of course, there is the story of flattening the curve. I think the whole issue of flattening the curve is actually most important at this time than it was at the very beginning. At the very beginning, when we spoke about flattening the curve, we were actually interested in being able to understand if our healthcare systems in terms of hospitals could actually accommodate the caseload that would happen. But now we reasonably have moved past whether we can accommodate the caseloads. We now know what our caseloads are. And really where we are right now is we're actually in a period where we're trying to do as much testing as we possibly can, reduce the number of overall cases, because we actually know what is a clinical case, a symptomatic case, and what should be done with the symptomatic cases, and how many of them actually need to get into a facility versus treatment from home, and then be able to manage the pandemic from that point. So this is a point where when we're talking about flattening the curve, we're actually looking at a complete different dimension from the dimension that we looked at the very beginning, when the biggest question at the point was, do we have healthcare facilities that can manage the amount of cases that we would have? So in today's world, as we continue to talk about the virus, this hop and spoke model is a very important model, because right at the break of the pandemic, we had what are today called the nerve centers or the task force. And that's literally where a lot of decisions were made, and there was trying to get an understanding of how to manage the virus, how to manage the spread. But 7 months into the game, we have now decentralized. We've actually really made the hub and spoke model really evolve. We moved it out of national centers, out of the Ministry of Health, and we've actually decentralized them, whether we've sent them to provinces or to states, down to district levels, to county levels. But the whole intent here is to be able to ensure the fact that as we do the decentralization of this task force or nerve centers, we're able to correlate the activities that are going to be going on. So it's the same kind of decisions that are made at national level are being made at the district level, at the county level, or even at community levels. But what you have is, in essence, the average connection per person actually reduces over the period of time. 7 months into the pandemic, that's where we are, and that's where most countries are, most communities are. So with that introduction of the standards and what is going on with the communities, I'm going to invite Joe, to please give us a conversation starting from what is actually going on with in terms of managing the pandemic, starting from a global perspective and then moving from the global perspective and coming down into what is actually happening in the labs and what is going to be the integration of COVID testing as we move forward. So, Joe, welcome, Joseph.
Thank you, Professor Killian Songwe. Our adaptation to the pandemic has been imposed by the presence of COVID. We have to adapt because it is, as you know, it's a killer virus. And as such, we're gonna depend on laboratory data in order to do tracking, treatments, and to prevent people from being exposed to various types of ailments.
Joseph, I think we're ready to hear you now.
Okay. Oh, you're not hearing me. So I'll start again. I'm saying that our adaptation to pandemic imposed by the SARS-CoV-2, which is commonly known as the COVID, can only happen if the laboratory tells us where the virus is and where the virus is going. With allusions to laboratory data, we can as such put together protective measures to combat the virus. As such, we can only go wrong if the laboratory data is wrong. Now, let's look at the global issues. When this virus came into play, the biggest problem that they had all over the world was availability of test kits. With the lack of availability, they could not track patients that were sick, so the disease spread through people that were asymptomatic. Those that were symptomatic, we did not really understand the virus that well to know that we have to isolate them, we have to wear masks. But all those came into play later on. Now, the availability of reagents, particularly here in the USA, was a very, very, very big issue because to test everyone in the USA, they needed at least 300 million tests, which a lot of companies could not produce. So as a result of that, they started testing the patients with symptoms. The patients with symptoms usually are limited by the presence of the disease. It takes away quite a lot of energy from the patients. So those patients don't go around too much. The patients that were asymptomatic were the ones that carried the virus around, and they were the principal spreaders. So it became a big problem on who to test. If you test the sick, only the sick, the spreading will continue. To test everybody, there are no reagents. So the FDA now started giving permission, started flexing and giving permission for other institutions to produce tests. Some of these tests were not sensitive enough and they were not specific enough. So it starts giving variation in results. Sometimes it will run positive, sometimes it runs negative. With that, when every test comes to the laboratory, we have to do a correlation to make sure that the kits are really working. So we run the test on multiple systems to see if they come positive. And if they're positive, then we know that those systems could be used side by side. Now, with the use of emergency authorization by the FDA usually have very strict standards. But due to the fact that they have to release those tests fast or they have to approve them fast, a lot of individuals started producing fraudulent tests that did not really work. And these fraudulent tests gave poor results to the patients. With the confidence that they are negative, these people went around and spread the virus more. expanding the pandemic. Now, how do we test? Like in our laboratory, we use the COBA 6800, which was really considered the gold standard because the US government put a lot of money in developing that test. So it was well developed. It was like the gold standard. But what happened is this. We were running back. It's about 20,000, 30,000 tests a week that we couldn't do. We started sending them to other laboratories, but they were overwhelmed too. So patients now were waiting for 2 weeks for their results. During this period, they just spread the virus around without knowing. So we decided to build a system which is as effective as the COBAs, 6800. So we contracted with a company called the Perkin Elmer, and they have systems which are liquid handlers like the Genus. They have the Chemagic, which is used to isolate the RNA. They have the Genus, again, that does the PCR plates. And then we use the thermocycler from Biorad. These are very, very high reputation companies. And with this system, it's very effective because the samples are not being manhandled, so they reduces the chances of error. All samples are barcoded, so the computer reads and tracks them. With this system, originating from Germany, we have a very, very, very robust system that we could really run up to 4,000 tests in 8 hours. Now, the next problem we had was the standards, the standardization. Who is supposed to run this test? Who? With that, the New York State gave an executive order that the laboratory should determine who they have trained and is qualified to run the test. So they waived the licensing provision, which is used to determine who can work in a clinical laboratory. They waived it just for the COVID test. So as a result, we could hire graduates, most of them foreign graduates who have come to the USA, but they have not yet adapted, they have not converted or transferred their credits, but they have the education. So we trained a lot of them, and they came through very, very, very productive for us. So as such, we could really handle very, very, very big loads. Now, information that is spreading around is that the CT value is very important in determining the cause of the disease. A lot of physicians have requested that I include the CT value in the results, but there is a problem. The problem is this: the CT value is not approved by the FDA as a means of tracking the probability of infection. So to include it in that report, we need to do a bridging study with evidence that that happens. And that is an extensive study that we cannot do in the middle of this pandemic. Now, the CT value also measures the concentration of the virus per ml, the copies of the virus per ml. This cannot be accurate because the virus comes in various volumes. The collection kits have various volumes of fluids. So some are diluted to a certain extent, some are over diluted, some are under diluted. If all came at the same volume, then that would be a stepping stone to say the CT value could be valuable. And even if they came at the same volume, it's still a problem of how the sample was collected. So the variability in volume, the variability in collection makes the CT value not as valuable. Now, for diagnostic purposes, we still use the CT value because when we have our thermocyclers going more than 40 cycles, we could really determine that that test is negative. So the CT value has its value, but its value is in clinical testing, it's not in diagnostic testing. The technical know-how of those collecting. Who is collecting the samples? If a physician collects the sample, they will collect it in a more invasive way, but it will be more productive. If someone who does not know the techniques of collecting does so, it becomes a big problem. And this problem will result in false positive or false negative. So the relationship between the viral titer and the disease could not be established using the CT value. There are other people bring different debates on it, but just from common sense, if the value is diluted from the start due to the volume of the collection kit, the CT value will be different. And that has nothing to do with the amount of virus collected from the patient. So those are some of the factors that we need to look into very carefully. Now, traditionally, we use the PCR testing in the laboratory for other things. And it is very effective because it takes one virus, duplicates it to the point of testing, then it tests it. This is different from the rapid detection kits, which tend to detect the antigens of what came with the sample. There's no amplification. So, and every test has a lower limit of detection. When you have something like the COBAS or the Perkin-Elmer systems, the virus is being amplified to above the level of detection, then it will test. But using the rapid detection kits, no, it doesn't amplify anything. It just runs based on what came in the sample. In this case, a lot of samples, up to 20% of them, will read below the level of detection, and it will be reported as a false negative. So the use of rapid kits is not really encouraged if PCR is available. Another point about rapid kits is the cost. Those who are obligated to follow the FDA standards can look at the list of the tests that the FDA has approved. They are really expensive, and it will be practically impossible, especially in Afrocentric areas or in Africa, for those things to be purchased by individuals, except the state decides to pay for them, or except they have grants that will cover the testing. Else, it's a big problem. Another issue with the pandemic is personal protective equipment. In the US, there was a big problem with personal protective equipment. But some laboratories like ours were lucky because we had a stockpile just because we ordered them from overseas, and the pandemic just met us at the right time with personal protective equipment. The use of biosafety cabinets in order to transfer those samples to is very important. I'm hoping that in developing countries, everybody doing COVID testing uses biological safety equipment. Now, laboratories that do rapid tests, I am not very convinced that all those new laboratories that do rapid tests have biological safety equipment or biological safety cabinets. If they don't, then spreading can take place through the personnel of the laboratories. Some people argue that how can spreading take place in Africa even without those productive equipment, because a lot of people are not being sick in Africa. But they have to understand that the African is a young continent. A lot of people in Africa are still very young comparatively. Their life expectancy in most African countries is around 55 years. I think that in the US is around 75 to 80 years. So you see, those older people are more susceptible. And so we should not misread the fact that people are not dying too much in Africa to be related to the fact that they are tougher. No, just younger. Young people in America too do not die from COVID, just the older ones. With this, I think I will be open to any questions that you might have. I hope that the contributions that we're putting will be fruitful. We're going to send a written document to you after we finish from here. So, Professor Songwe, over to you. Is Professor Songwe there?
Joe, again, that was great. Thank you so much indeed. As always, it's always nice to have these conversations with you and to see where we are with the big picture of what is going on with the testing around the world and how laboratories should be able to look at. But there is an area I want to go back into just a little bit because you mentioned, and that's the question on CT values. Because so much has been said about this cut-through values, and there's been so much decisions that have been made on them, and there are different equipments that are out there, there are different platforms, and there are different protocols that are going on for reading for actually making a decision about positive and negative results on tests. But you raise and you touch on something really important, the value of the CT values, and in their direct relationship with what is the volume of the transport medium. And that's an area, if you could just go back into that again and just reiterate what you said with some more information, I think that would be very useful for a lot of our technical people who are measuring because we have traditional kits that come and they have 2 mLs of transmission transport media. We have areas, just because they are hard to reach areas, that do not actually have the right transport kits. So they are making do with what would today be called vaginal swab containers. And that is a whole different thing. And you really raise a very important point with that. So I want you to just go back into that conversation and let's say some more about the relationship of the volumes of the transport media with the results that we get, and especially with the CT values.
Yes. The CT value takes the initial number of viruses and amplify them to a testing level. If you start with a big viral load, the amount of cycles that you need to achieve the testing level is low. If you have very, very few viral cells in there, the amplification will take many, many more cycles. So the thing is, if we have 2 patients of the same viral load. Let's assume two patients have the same viral loads. And you collect samples from those two patients and put one in a 2 ml tube and put one in a 5 ml tube with liquid. The one in the 5 ml tube will be over diluted and the viral concentration per ml will be very low. When you run them on something like the covers, what will happen is that the one with the more concentrated sample with the low volume will have, let's say, 18 cycles. It will read positive. The one that had a bigger volume of liquid will go close to maybe 20 to 30 cycles. And so if you look at the CT values, you will see one is 18 and one is 30. You're going to say that the patient with 30 copies per ml, the patient with 30 copies per ml had a lower viral load. That's what the CT value will tell you. But the CT value doesn't tell you that that sample was over diluted. This makes the CT value not to be very, very, very useful. Another thing about the CT value is this. When you want to collect samples, some people will just collect samples from the nasal samples in a very shallow way. Some will be very invasive and go right dig into the sinuses to collect samples. The amount of virus collected is different from those two different things. So now we have put into question the volume over diluting the sample. We have put into question the collection technique that results into the inoculation of the samples. We've put into technique the technical know-how of the person collecting. Now I can even add, I can put into question the resistance of the patient to sample collection. All these variations will give variations in the CT value. And if the more variations we have, the more the CT value varies, and the more the CT value becomes useless, virtually useless. So I think that people should not concentrate on the CT value because it will give wrong predictions, except everything is standardized, and except the FDA standardizes the collection kit volume, the method of collection, the type of swabs used, then we could sit and say that, okay, this collection is standardized, so we expect the value to be standardized.
Joe, you get right into the crux of the matter for us here. The whole reason why we do these webinars and the reason why we tie them up to the International Organization for Standardization is really because of what you've just said. There has to be a standard around this. There actually has to be a very defined protocol as to how the test is going to be done, how the sample is going to be collected, how the testing is actually going to be done, but most important, how the testing is going to be read. I think that is really crucial in all of this. And I must say, Joseph, I think with this conversation, I think what we've sorry, looks like I've been going on without my volume. But I just said, Joe, you actually put an accent in terms of the utility of these webinars that we do. And the reason why we associate them with the International Organization for Standardization is just because of this. We are talking about collection, and the collection procedures have to be standardized because it has a direct impact on results. We're talking about the medium and the volume of the medium in which the sample.
Your mic is off. Professor, somewhere your mic is off again.
It actually accentuates the event of people going out who actually should have tested positive, but because the medium actually diluted their volume, they are now going on and they're going around as negative when they actually are positive. That's a really big issue. But you also touched on something which I really want to follow up on. That was the use of rapid detection kits. Right now on the African continent, we're now just beginning to build numbers. And yes, you also brought up a really important point. That's the issue of the age bracket on the African continent and the caseloads that we're seeing. Directly correlated, the age, the population age of the continent is pretty much an average of 55. And when you look at it compared to our European or US counterparts, it's a completely different story. And so that is really crucial. But now talking about the use of rapid detection kits vis-a-vis PCR kits in symptomatic patients, what is your take on the rollout of especially antigen kits today and the use of PCR? What would your take home be in this particular area? Because that's something that on this continent we're going to start looking at now. There is the need to roll out rapid detection tests. And we're now looking at the rolling out antigen test. But again, you also mentioned in your presentation that there is a 20% error, which is in my thought, I think that's very high. But let me hear what you have to say with regards to antibody rapid detection test, antigen test, and PCR test for clinical situations.
Yes, when we go to rapid detection, everyone involved in this business accepts that they're not very effective. The only reason why they become valuable is that the main suspicion, just the suspicion that you've been exposed to COVID, quarantines you for 2 weeks. If you are positive, you are still required to be quarantined for 2 weeks. So the only reason why we test is just because of spreading. We don't want it to be spread. Now, if you use the rapid detection kit, you know with 80% certainty that you don't have the virus. There is a 20% chance that you have the virus. That does not clear your mind at all. It still puts you in a situation that which you question yourself, do I have the virus? Don't I have the virus? You don't know, because the kit does not answer the question. When you do PCR and it is not detected, you know for sure that even if you have a virus, is below the level of detection. And if it is below the level of detection, there is nearly no chance that you can really spread it that easily. It will be more difficult to spread it. Now, symptomatic patients, we are hoping that symptomatic patients will have a very high viral load at the point in which they have symptoms. With that very high viral load, I'm assuming here that the rapid kits will be very effective. But once the viral load starts going down, it will start missing the positives, or it will start giving false positives. So the high viral load, I'm not worried about. I think the kits will pick it up. If you look at our evaluation of these kits, we selected those that have the lowest level of detection. There are kits that are approved by the FDA that have, okay, for example, Cobas has 18,000 copies as the approved lower level of detection. There are other systems here like the Attila. It has 540,000 as the lower level of detection. So you look at this comparison, you know that everything that half of the things that Cobas call positive, Attila will call negative. So I just giving you an example of the variation. But you know, when initially companies present these results to the FDA, they go and reevaluate and do other presentations. I might be giving you old information, but at least it will help you to differentiate between the importance of the lower level of detection. And no matter how bad the PCR is, it is better than the rapid detection kits in the sensitivity of the test.
Okay. Thank you, Joe. You just really ramping this up, and I think we could go on and on between yourself and me, just trying to have a discussion around this, because we're actually in a state where there is a progression of what is going on. But let's just open the waves here and see if people have questions for us. If there's anybody with a question or a comment, if none, I think I still have one more to go. But let's listen to the people who are listening to us out there. If they have any questions for yourself or for me, or any comments at this time. Okay, I think we're waiting to see. There is none at this time, but as we wait for any comments or questions out there, I think there are two really important things that continue to come up. Africa as a continent is going to be considered a resource poor state as we look at things today. And the real question now becomes, as the numbers of cases continue to grow on the African continent and the PCR testing, the real question becomes a very economic question. Are we going to be able to foot the bill to continue to do a PCR test? At what point do we actually decide to bring in a whole other range into this whole discussion? And that's going to be the range of asking, can we start doing pool testing at this point? Because we know what our prevalence rates are. We know what we're seeing. We still have very low numbers. Would this be the right time to actually consider doing pool testing? And the reason would be prevalence is low, economics of doing the testing is high. Could we actually start considering pool testing for now until we actually start seeing a really high number of cases? What's your take on that, Joe?
Okay, let's look carefully at pool testing. We have a pool, let's say of 4, right? 4 patients. They pool 4 patients together. I'm just taking a low pool. 4 patients together. One of them is a low positive and 3 are negative. What happened to the low positive? The low positive will be overdiluted. Just the same thing we said. And when it's overdiluted, that low positive will be taken below the level of detection. Now, let's assume that you do the pool and one person is positive. You still have to test everybody individually. So are we really sure pool testing is cheaper? Well, you said it something very correct. The percentage of infections are, when they are very low, pool testing might be good. And it might be good because it will reduce the number of tests and will help economically stressed individuals to get testing. But the issue is, does it really give us the values we want? Does it really tell you if you are positive or negative? I have my doubts. Pool testing started in big laboratories here in the US, like Quest Diagnostics, but I think they quickly stopped it because it is not cheaper and it really costs repeating of tests. But if you have a very, very low percentage of infections or the incidence is very low, then maybe pool testing will be helpful. But again, I'm warning, pooling will dilute the positive person who has a very low viral load. I am very sure about that. Audio. Yeah, audio.
My own. Thanks, Joe. I think we could carry on this discussion for as long as COVID is going to be with us. And I think just as we started off talking about emergency use authorization, I think the whole field is still in emergency use authorization. And we're going to keep on watching what is going on, what laboratories are doing, what different laboratories are doing in different parts of the world, and how we can actually continue to develop and what innovations we have around this. And we will continue to look out to you to give us some more insight. I really, really love the idea of thinking about the dilution levels and the loss in the viral load when we have these dilutions, because that's an element that really hits big on the results that are out there. But it doesn't just hit big on the results that are out there, it hits big on the percentage of infections that are going out, because basically with pool testing, a low viral load becomes negative, and what we're actually doing is we're giving the person an authority to go out and infect other people, because we've actually given them a negative result. However, their viral load, they're just beginning to shed, and as a result, they're going to become symptomatic. But by the time they become symptomatic, by day 10 and day 13, they would have already had enough time to increase the number of contacts that they will be in touch with. So this is a really tricky area. And just as I go forward here, of course, we now know our most famous patient, and we're just glad that the whole idea of wearing the mask is just beginning to come center forward. We wish him well. We also know our previous very famous patient, Boris Johnson, who is well now. And it's a good sign. It means that people are going to fall sick and people are going to get well. But as we go on, and just before I close, I don't want to be able to stop without talking again about the things we have to do to wash our hands, continue to use soap, water, sanitize, and above everything, I think wearing a mask and keeping a social distance is just very, very important in us to continue to manage the COVID infections across the world. I thank you so very much indeed, Joe, for joining us today. We look forward to having you again as we find out some more things in managing the COVID testing. I think the big take home today is to look at what is the impact of the dilutions that we have in our transport medium. Are we using an approved volume? And when we talk about pool testing, for a lot of the resource poor countries that are considering pool testing, is to actually think about when you do the pool testing, what happens to people with very low viral loads? Do they also get diluted when you have a 1 to 3 as the example that you gave? I think that was very, very interesting, very good insight from somebody who is doing as many testing as you are doing out there in New York. Thank you. Look forward to seeing you again. And to the rest of you who are watching us from wherever you are today, I thank you so much indeed for joining us. I look forward to seeing you next week, same time, same place, as we delve deeper into some more issues around testing and their relationships with rapid detection, the test kits, and all the other things that would benefit us as we go forward, and especially the integration of COVID testing in our regular testing lab.